Right, welcome everybody. It's 2 o'clock. Let's crack on with the second session of our conference this afternoon. So this afternoon we're going to be looking at firstly looking at malnutrition and some of the interventions, and then the second half of the afternoon looking at intergenerational cycle of violence. So just want to introduce our co-host for the first session this afternoon. Is Nozipho, is a dietitian, academic, and researcher from Hero, based in Joburg, and we're talking to us a little bit about the context of nutrition, and then handing over to some of the other speakers. So, Nozipho, I think we're gonna. It's after 2 o'clock, so
Hello.
I think we can at this point let you take over and start with your content for this afternoon. Over to you. Thank you.
Okay, great. Thank you, Dave. So as Dave alluded to, I spoke to, my name is Nozipho, and I'm from the Health Economics and Epidemiology Research Office. I am just going to introduce my co-chair, who's Ntando Mbata, who's from the University of Pretoria. She is a lecturer there and works in nutrition and dietetics. She's going to she's going to introduce our next speaker, but I think on our program, it says Shwaib was going to speak, but unfortunately, Shwaib had an emergency today and could not attend the session. So what I'm going to do is just give a brief background of what is happening in the nutrition world, and then I'll hand over to our next speaker. So right now, I'm just going to share. So I think you're seeing it's not in presenter mode. All right. So malnutrition. So these
Sorry,
are just
Nozipho, can you change the display settings again?
okay, perfect.
Just to swap that. Yeah, there we go.
All
Perfect.
right, perfect. Yeah. So malnutrition is a big problem wherever we go, and here in South Africa, it's no different. One in 3 children in South Africa is facing some sort of undernutrition every day. And every 2 minutes, a child in sub-Saharan Africa dies from malnutrition. And as I've already said, 1 in 3 of the most vulnerable face undernutrition daily in South Africa. So this session aims to unravel undernutrition, looking at wasting and stunting in a middle-income country. So in terms of agenda, I'm just going to give some definition and statistics, understand the landscape of acute child malnutrition in South Africa, look at some data statistics, look at causes, framework, the context of South Africa, have a question and answer session, and I'll close. So in terms of definition, wasting is defined as having a low weight for height. This is also known as a child who's too thin for their height. And the weight for height is a measure that is used, and WHO has come up with a criteria. And acute undernutrition is often resulting from recent illness or inadequate food intake. So the health impact is that there's an associated high risk of mortality, and it reflects a short-term nutritional stress. Whereas stunting refers to low height for age. This is a result from prolonged poor diet, recurrent infections, or inadequate care. The long-term impact is deprivation linked to impaired cognitive development, poor school performance, and reduced adult productivity. So looking at South Africa, despite being classified as a high middle income nation, South Africa continues to grapple with alarmingly high levels of poverty and inequality. So of particular concern is the fact that a quarter of the nation's children live below the poverty line, which exacerbates their vulnerability to malnutrition. And we need to come up with strategies for closing the gap in acute child malnutrition care, as well as the chronic malnutrition. So this is based on a slide shared by UNICEF that about 2.5 million children in South Africa are now growing well. Over 1.5 million children, which is 3 out of every 10 children, are stunted. And this was based on 2016, but currently the figures are worsening, and 140,000 children are wasted, and 1 in 7 children are overweight. So what we see is that less than 1 in 3 babies is exclusively breastfed. And I think some of the previous speakers spoke to that. If we go on, only 1 in 5 children aged 6 to 23 eat adequately. And as alluded in the previous sessions, 1 in 7 children is born with low birth weight, and this comes from maternal undernutrition, looking at inadequate care and unhealthy diets. So this graph shows just the infant and young feeding practices. 31% are exclusively breastfed. Only 20% get a minimum adequate diet, whereas 61% do get eggs and flesh food consumption, but it's not always the healthiest foods, whereas 37% have zero vegetable or fruit consumption. So for me, the point that I wanted to note here was only 20% get a minimum adequate diet, which is a problem. So why should we be concerned about child malnutrition, especially severe acute malnutrition? So why we should be concerned is that because of the country having a high Gini coefficient, that means there is a very high inequality. Those who are affected the most are the poorest and the youngest children. So we see that the poorest and the youngest, 12.3 times are more likely to die from severe acute malnutrition. This is whether it is a direct result of malnutrition or an underlying cause in a disease. And there's also an increased risk of chronic disease related to childhood undernutrition. And there's an increased risk of poor developmental outcomes. And usually there is a relapse after treatment of severe acute malnutrition. And there's the co-occurrence of stunting and wasting. This leads to at least a 1% loss of GDP in South Africa, which means annually we are losing about 40 billion rands every year. So in terms of government initiatives and policies, there are already a number of existing policies related to child malnutrition. And South Africa's political, legislative, and executive structures showcase an abundance of policies which are available, although there might be lack of collaboration in some of them. But when we look at policies like the food security policy, there is some alignment with food safety and strengthening the nutrition focus. And we have seen from healthcare professionals in the front lines, from Limpopo and KZN, they have spoken about how they deal with acute malnutrition that shows up in the hospital. So the inpatient care, they've got rigorous implementation, they've got standard protocols and casualty care to stabilize and manage acute admissions. But there's a need for improved data quality. However, I beg to think that a child who comes to the healthcare facility is already at an advanced stage. Something should be done before they get to this. So when we look at the causes of undernutrition, there's a framework that already exists that looks at the basic causes, underlying causes, and immediate causes, and how these all lead to the short-term consequences we see and the long-term consequences, which can ultimately develop in an intergenerational situation where we see a child is born malnourished or stunted, and later on they give birth to a child who's also malnourished and stunted because of the environment as well as inadequate care practices. So looking at the South African context in particular, some of the main challenges that cause malnutrition or undernutrition especially It's poverty and inequality, food security issues, healthcare access, HIV/AIDS, maternal and child health challenges, water and sanitation, education, cultural practices, political and social factors, and things related to climate and agriculture. So what are the benefits of solving undernutrition? The first thing is that we boost our gross domestic product. We reduce healthcare costs. We improve economic competitiveness in our world. We increase investment in human development, and we eliminate intergenerational poverty. So looking at those few things, this is one of the reasons why we need to really solve the challenge of undernutrition. And in summary, when the health of children is emphasized, we have a reduced child mortality and long-term morbidity. And because undernutrition is an underlying factor, it's important for us to focus on solving the challenge of undernutrition. What has been noted is that for every $16 spent, there's a for every dollar invested in nutrition, there's a return on investment of $16. And then when we strengthen PHC, ECD, and social protection linkages, we see that undernutrition disappears. And when we solve the challenge of undernutrition, those who are the most vulnerable, those in the rural areas, those who are HIV exposed and poor, we see more equity. And worldwide, child morbidity and mortality is an indicator of a nation's economic development, health system strength, and overall living conditions. Therefore, if we solve undernutrition, we have solved a big chunk of what causes child morbidity and mortality. So as I mentioned before, undernutrition leads to at least a 1% loss of GDP to South Africa. That means when we have the challenge of undernutrition, we're wasting 40 billion rands every year. So that's the end of my talk on malnutrition. But now we are going into a further session of looking at the proposals that have been given as solutions to undernutrition in South Africa. And I hand over to Nothando. Thank you.
Our next speaker is Dr. Edzani from Grow Health. They deal mostly with stunting. So we've invited her to come for this session to just share a bit on what they've been doing and how we can go about to tackle this problem that we have of malnutrition and especially stunting in the country, which doesn't seem to be letting down, but it's growing and growing all the time. So we'll give it to Dr. Edzani and then we'll come back with the questions for anybody who has questions. Thank you. Dr. Edzani.
Thank you so much, Nothando, and good afternoon, everybody. Just wanted to see me, and I'm going to now switch off my camera. Thank you so much. As Nothando said, I am from Grow Great, and I'm going to be speaking about a little bit about stunting, our organization, and what we've been doing as an organization to try and respond to this enormous challenge of malnutrition in South Africa. So I'll just go, that's the outline of the presentation. So at Grow Great, our vision is to see a South Africa where every child reaches their full potential, and a South Africa where every child's body and brain grows great from the very start of their lives. Our mission is to mobilize South Africa to have stunting in young children by 2030, focusing on the first 1,000 days of life. I'm not going to go again over the definition of stunting that's been shared already by Nozipho. And really just again to outline the issue and reemphasize that we have 1.5 million children in South Africa who are stunted, with a prevalence of around 27 to 28%. but that prevalence for under 5 masks a much bigger problem in the children under 2, where we have nearly 35% of children under 2 who are stunted, and up to 42% of children aged 18 to 23 months who are stunted. So in South Africa, for every child who suffers from SAM, there's approximately 135 children who are affected by stunting. And we have the highest stunting levels amongst upper middle income countries. And we're the only country amongst our peers who's not progressed since the 1990s in terms of reducing stunting. It's important that we address stunting and we address it urgently, as Nosipo mentioned, because a stunted child is a stunted society. And stunting affects both physical and cognitive development. And a child who's stunted is more likely to start school with developmental delays, perform poorly at school, be unemployed when they grow up, and to suffer from chronic conditions such as diabetes, obesity, hypertension in adulthood. And there's a massive loss to the economy each year of over 40 billion rands. But stunting never occurs in isolation. It usually occurs with other forms of malnutrition. And in South Africa, this is the picture. Stunted children are more likely to be obese than normal or underweight in South Africa. And the relationship between stunting and wasting, it's understandable because the two forms generally are expected to occur in the same child because the causes are usually related. Worldwide, there's over 15.9 million children who suffer from both acute malnutrition and stunting. And those who suffer from both malnutrition, acute malnutrition and stunting are more likely to have higher mortality rates compared to those who don't have co-currents. And a child who's just moderately stunted, who's just moderately wasted, but happens to be concurrently stunted, has equal risk of prognosis to a child who's severely wasted. And in terms of understanding the linkage between stunting and obesity, it's sometimes counterintuitive, but the Becker hypothesis, which is also known as the developmental origin of health and disease theory, life conditions affect their risk of disease later in life. We see that low birth weight, children who have a low birth weight are 3 times more likely to be stunted. And low birth weight is a very strong predictor of stunting, whereas stunting is a very strong predictor of obesity in later adulthood. So it's imperative that we act in the earliest years, and in fact, in the time in pregnancy, for us to have the biggest return on investment in terms of our health interventions. The theory explains that if there is malnutrition during pregnancy, what happens is that the fetus adapts to an environment of deprivation and starts being in an energy-saving mode. After birth, if they then get exposed to, generally what they would get exposed to if their mother was malnourished in pregnancy, a diet which is high in calories, with high energy and low protein, the child never loses the adaptations that they developed during pregnancy. And this generally then results in obesity and many of the metabolic manifestations. In the South African context, the key drivers of stunting are intergenerational influences such as persistent poverty, poor feeding practices, gaps in vitamin A and routine deworming, late or limited antenatal care, poor maternal mental health, poor wash, and poor indoor conditions. But most importantly, the strongest predictor of stunting in South Africa and elsewhere is maternal height and low birth weight. But the good news is, from a study that we conducted in South Africa, it was clear that if these modifiable factors are changed, whether a child's mom was already stunted or they had a low birth weight, if their vitamin A and routine deworming is up to date, if they live in a household with adequate sanitation, if they eat a diverse, nutritious diet, and importantly, have a mother with good mental health, they're unlikely to be stunted. Suppose the question which we keep asking ourselves all the time is, if South Africa invests so much money per capita in children, why do we still see children who are malnourished? What is the government doing, and where is the gap that we need to fill for interventions? So we know that the child support grant has been a key intervention in addressing child poverty. But at this, most children only access it after the age of 1, and it is now its value has eroded over time, and it is now below the food poverty line. There's been a maternal support grant policy which has been in the works since 2013, but it has never been implemented. Nosipo spoke about the National Food Nutrition Security Plan, and there's a current draft that's underway. But still, we're hoping that we see more action and actual deliberate action and intervention to reduce child malnutrition in South Africa with that plan. There's currently a national strategy for accelerated action for children that's still not been signed off, that requires cabinet sign off, but that supports and backs stunting reduction and malnutrition, in particular in children. But that still needs to be signed off for it to be implemented. There's been a huge boost in early childhood development investments, which have increased the early childhood subsidy from 17 to 24 rands, hoping to extend the reach to more than 700,000 children. There's money that's been set aside for a pilot, but up to date, that money has not been spent to try and test meal provision in ECD centers. The South African early childhood strategy lacks a clear service plan for children who are 0 to 3. It's got a very strong focus on center-based services for children who are 3 to 5. And from the Thrive by 5, it looks quite clear that children who are in early learning programs are protected from stunting and malnutrition. So what is the gap? The gap is that there is no coordinated effort to target the first 1,000 days. We all know that malnutrition disproportionately affects children 0 to 2 years. We all know that the children who die from malnutrition is mainly children 0 to 2 years and not children 4 and 5 years old. Yet, these infants and toddlers who are aged 0 to 2, who are outside of an early learning center, receive no nutrition-specific support beyond the child support grant. The child in a registered early childhood center gets a meal which is subsidized by the ECD subsidy from government. And the child who's in school gets a meal which is subsidized by the National School Nutrition Program. Yet, their youngest sibling receives no nutrition-specific support from government, which starts to have us thinking around where the gap is and where we need to be acting. So South Africa's policy architecture still leaves the first 1,000 days largely unprotected, despite this being the period of greatest vulnerability and fastest body and brain growth, and the only window when stunting can be decisively prevented and deaths from malnutrition prevented. Grow Great closes this gap by delivering evidence-based malnutrition reduction programs that equip mothers and caregivers with the knowledge and access to services that promote optimal child growth and early childhood development in the first 1,000 days. For us, it is very clear that if we want to end stunting or any form of child malnutrition in South Africa, it needs to start with deliberate action in the first 1,000 days. So how is Grow Great contributing to the solution? Firstly, we're generating and using data to advocate for change. We started by conducting community-based stunting surveys across 9 food vulnerable districts in South Africa. The only data which is representative at a district level, at a granular level, which is exactly the kind of data that we need to target interventions. Our current surveys are only representative at province level, although they do report prevalence at district level, which can be misleading in terms of resource allocation. So if we do studies, what else do we do on the ground? Grow Great has 2 flagship programs, Grow Great Champions and Grow Great Flourish. And we are currently in 20 districts. We're in 8 provinces across 20 districts. This is one of our community healthcare workers from Limpopo doing a home visit. And really, truly, if we want to fix things, we need to do first things first. We can't fix what we can't see. And growth monitoring by community healthcare workers makes undiagnosed child malnutrition in the community visible and preventable. The question is, can it be done and does it make a difference? From our point of view and our experience, it is possible. Because with very little resources, in partnership with the government, we've been able to train to date 4,000 community healthcare workers who have reached over 450,000 vulnerable children and 90,000 pregnant women. Our program is geared around onboarding, training, equipping, and motivating community healthcare workers. Grow Great Champions trains, equips, and motivates community healthcare workers to serve as frontline champions for maternal and child health based on government's guidelines. We provide them with a starter pack containing of a client folder, stationery, first 1,000 days resources, growth monitoring tools, and a digital scale to start them on their journey to supporting women and children in the community. In selected pilot sites, they also receive a smartphone and which comes with the community healthcare worker app, which we use for patient data recording, but it's also a tool that helps to train the community health worker on the job. We also train the outreach team leader to support the community healthcare workers in the field and ensure that they're providing quality supervision. So empowering community healthcare workers to be champions for young children should be a key priority in South Africa, where we have increasing levels of malnutrition. It matters because malnutrition is currently invisible. We only see the children who are dying at clinics. Community healthcare workers already visit homes. We need to equip them to detect and act early, as we all know that early detection saves lives and prevents malnutrition. What this requires is for us to scale the training of community healthcare workers so that they're able to growth monitor children accurately, help caregivers to use the Road to Health booklet as a reference guide, counsel caregivers, and provide immediate guidance on nutrition. In addition, they need to be able to refer high-risk children early, and we need to equip them with growth monitoring tools so that they can provide integrated child growth monitoring as part of their routine home visits, which is what the Grow Great Champions project has been doing, but this needs to be scaled and adopted by government across all the provinces and the districts. The impact that we'll start to see is early detection before malnutrition becomes life-threatening. And everywhere where we've started and where we've trained, they start having increasing levels of MAM and SAM as community healthcare workers start identifying children at risk. This prevents stunting, and it ensures that targeted nutrition support reaches the right families and creates a real-time community picture of child nutrition. When our communities visit homes, they focus specifically on these activities. They ensure that they test pregnant women in the communities and ensure that they book their pregnancies early. They screen for maternal mental health, they screen for maternal malnutrition, all of which are drivers of malnutrition and in particular stunting in children. They screen for substance abuse, they screen for the child, if the child is on the child support grant, and counsel the mom on how to make sure that she gets that on time. They do developmental screening and provide regular monitoring of growth to the children. And they also use this community healthcare worker app, which is on their job tool, which helps them and gives them prompts and allows them to be able to make the right decision so that they refer the right children with the right agency. The big question is, does Grow Great Champion work? We have conducted a retrospective chart review, looking through our files that we've been creating from 2018 to 2024. We had 14,000 files that we were eligible for inclusion into the study, and we randomly sampled 2.7 thousand files. And these were the results. From the results of the retrospective review, we're seeing massively high levels of exclusive breastfeeding, almost 3 times those of the national average. If we want to improve exclusive breastfeeding, I think it's very clear that community healthcare workers are a key agent in promoting that in communities. The same with vitamin A and deworming. We saw almost universal coverage of vitamin A and deworming in the children that our community healthcare workers were visiting. Importantly, we saw that 51% of the children who were stunted at 6 months recovered by 24 months, which is very encouraging for the program, even though this data was not compared to a counterfactual. But in terms of dosing, it's clear that the more a community healthcare worker visits a child, the less likely they are to be stunted. We also have the Grow Great Flourish program, which supports mothers and helps them to adopt behaviors that prevent stunting and enable responsive caregiving. This is a Flourish class where mothers come together, support each other with a facilitator who helps them through all these topics, which are critical for optimal child growth. And does it work? Our results tell us that it does. The average stunting levels for a Flourish cohort, when we did this alumni study was 12% compared to the national average of 27%. And all the mothers who attend Flourish show an improvement in the self-awareness, self-care, and most importantly, in responsive caregiving around nutrition. And they have the most beautiful reflections after they've attended the Flourish classes, which I think capture the essence of what happens when you bring women together with the right knowledge and the right space to be able to ask questions so that they can be able to practice the behaviors that they are told to practice at clinics without explanation, because our system is overburdened and our nurses do not have time to sit at length and counsel patients on these issues. One client said, clinics are where we go to get healthcare. Flourish is the school of motherhood, where we learn as much from one another as we do from their host and build lifelong friendships and support. Another mother said, I never believed that a baby can survive on breast milk alone for 6 months until I tried it after learning this from Flourish and getting the support from the other Flourish moms. Another mom said, I started taking my supplements as I should, and I try to eat correctly. Another mom said, as a working mom, I stopped formula feeding my baby and started to express breast milk for my baby after attending visit 7 of Flourish, because in the class, I learned of the importance of breastfeeding and its benefits. So it's clear that women want to do the best for their babies, and if they have the right knowledge, they will do it. But what about food affordability? As Grow Great, we've been piloting many projects to try and really link the mothers to food, because we know that clinics do not prescribe food. But we've partnered with Food Forward, and we're seeing great results in areas where we're working together, where when we identify a child who's malnourished, we then link them up to food parcels. So far, this pilot demonstrated that community health care workers are key agents in early intervention and prevention of malnutrition. It is possible to equip community health care workers with tools, skills, and knowledge to identify children and pregnant women at risk of malnutrition, and it works. And when we collaborate, we can ensure that every malnourished child a community health care worker identifies is linked to care and food and reduce malnutrition significantly. We can't wait for tomorrow. To close off, we are advocating as Grow Great to make protein-rich staple foods more affordable, because no matter how much we tell our patients and their mothers and mothers of children that they should eat healthy, high-protein food, if they cannot afford it, the children will not get it. I think my time is up. I'm not sure if I have 30 more seconds.
Yes, you can finish up, Dr. Edzani.
Okay. We also advocate for the maternal support grant, because we did a study which showed very clear results that when women are supported in pregnancy with financial resources to be able to buy food, there's improvement in the hunger in their households, their children's hunger, and their mental health. We are also collaborating with the Western Cape Department of Health, where they have launched a project called Kulisa Care, which is a multi-sector pilot program to prevent stunting. The purpose of the program looks at women who are underweight, women who have a low birth weight baby, and women of babies who are born low birth weight. And in the program, these pregnant women who are underweight or who have a low birth weight baby are provided with a monthly nutritious food voucher of protein-rich foods, partnering with ShopriteShop, and a comprehensive primary healthcare support delivered through trained community healthcare workers, the same community healthcare workers that we train. And really, this is the kind of solutions that we want to start seeing in South Africa. We need to be able to start prescribing food in our healthcare facilities. through this kind of collaborations. So what should we do now to reduce and prevent malnutrition? We need to focus on the highest risk groups, the first 1,000 days, infants 0 to 24 months, and poor pregnant women. We need to train and equip all community healthcare workers for community-based growth monitoring and early identification of children at risk. We need to provide pregnant women with food vouchers and maternal support grant, which is equal to the child support grant, because this is where a child's genes are determined when there's no malnutrition, for that child to struggle for life and to be doomed to a life of never reaching their full potential. Pregnant women and mothers must receive peer-led, clear practical counseling on what they and their children need nutritionally, including age-appropriate feeding, responsive feeding, and affordable nutritious options. We need to make protein-rich staple foods more affordable. We need to support families to grow their own food. And we need to link identified families to food support and social protection through food redistribution and rescue, avoiding food wastage. Thank you so much. I hope I have implemented some of the recommendations that Yako was talking about earlier on. Thank you.
Thank you so much. Thank you so much, Dr. Edzani. Very insightful. And I've been around places where your Flourish program has been implemented, and we've seen tremendous results, especially amongst young girls who are pregnant and HIV positive. So it's been working well. Unfortunately, it seems that in some places you guys have stopped implementing the program, but it was working very well. And also what I appreciate about your slides, it's how you spoke about mostly nutrition sensitive interventions instead of just nutrition specific. Because if you only take care of an immediate cause of hunger, what happens afterwards? Like you said, they go back to families, there's no food in the house. You can't only just feed the child who's been to the clinic. So government should be more focused on things that are nutrition specific, things like your food gardens, your WASH programs, your finances, and training for women to actually take care of themselves and their children. So thank you so much for that. And also just on the stunting issue, lastly for me, I find that in our public sector, there's not a lot that is taught to healthcare workers. Their knowledge on stunting is very, very minimal. We don't focus on those things. We just focus on the same cases, but we don't actually look at stunting. If you were to go to a healthcare facility and ask how many nurses know how to diagnose or screen for stunting, is very few. And we actually don't even have the proper measures that are the tools to actually screen for stunting. We don't have tape measures. We don't have height for weight studiometers. So it's really difficult to find the actual numbers of stunted children in South Africa. So thank you so much for that. And then I don't know if Nozipo wants to say something, or otherwise I will go to the question and answer session. Nozipo?
I just want to say thank you so much, Dr. Edzani. I think that was a very insightful presentation with the numbers there proving that it really can be tackled. It's just a more collaborative effort and having everyone come in. So I think I'll let Notando discuss the next part, which is the question and answer session. I feel
Yes.
we have, yeah, go ahead.
We've got a bit of time, yeah. So we're just going to open up the floor to anyone who has a question that they want to ask, or even has a response to any of the questions that are going to be coming up. And I will start with some of them that are already up, and then anybody can answer as well. Somebody commented on how they've noticed that young girls prefer to formula feed instead of breastfeed these days, no matter how many times they've been taught about the benefits of breastfeeding, but they opt for formula feeding. I don't know if there's an answer from the floor and how we can actually help. Yes, Harun.
So I'm going to be a little bit controversial and be a little bit critical of the presentation, and maybe Dr. Edzani wants to respond. So what I've heard is that the community health workers offered 3 interventions. One is offered growth monitoring. Secondly, offered health promotion and health education to caregivers. and thirdly, offered referral to clinics. And what I've heard is that that intervention resulted in a 51% reduction in stunting. I'm kind of very skeptical of that result. And I suppose my first question to Dr. Edzani is, has this actually been peer-reviewed and published? And so let me explain my reasons for skepticism. The international literature shows that as a stunting prevention or treatment measure, growth monitoring itself it has got very little value. The value of health promotion as well is very limited. The combination of growth monitoring and health promotion has got weak evidence of support. And the whole idea of community health workers referring to health centers, there isn't much literature on that, but one knows that once stunted children are referred to clinics, in most clinic settings, there's no intervention. There's nothing you can do at a clinic level, except perhaps offer some kind of nutrition supplements, which happens rarely for children with stunting. So I'm skeptical that with the intervention as proposed by GrowGrade, you can get a 51% reduction in stunting. And so perhaps if I've misinterpreted the fact, Dr. Edzani, you can perhaps correct me, but I'm not sure I believe these results. And as I said, has this actually been subjected to peer review? Over.
Thank you, Harun. Dr. Enzane?
Thank you so much, Harun, for your skepticism. Yes, you are right to be skeptical. And I think this results come with a huge caveat that this was not an RCT. There was no control group, and this was based on dose response. But also, I didn't include a lot of the other slides because of time, but also these children were starting off at very high levels of stunting, because obviously this is an intervention that is targeting children who are stunted. So in terms of the drop, it's not a drop from 15%, it's a drop from 38% down to at the end in the end at 2 years, sort of like an average of 30%, which is obviously much lower than the average at 2 years, the national average at 2 years. But yes, it does come with that big caveat that it's not a rigorous study. This is not a study. It's in fact an implementation study, and really using programmatic data in real life. And we do know that there are issues around how community healthcare workers was it accurate, was it not accurate, missingness in the data. So I do agree that there are big caveats to it, but definitely there is a reduction in stunting. Might not be as big as this if we're to conduct a rigorous quasi-experimental study or an RCT, which is the next level of evidence that we're going to be looking for. And we'll be looking for partners such as yourself to really help us think through how we ensure that we get rigorous results that help us with this. And I think that the more important things that we've seen, that we believe, is the shift in behavior and also the shift in the lead indicators for stunting. So we see a much high levels of vitamin A coverage in this group, high levels of deworming, high levels of exclusive breastfeeding, which is of course also self-reported, but it's something that every time that I've done a site visit, the moms really understand it, and they're like, yes, we know we only give our children breast milk. So there are a lot of positive indicators that can say if these behaviors are changing and mothers engage more with their Road to Health booklet, they understand what to do when a child is having gastro, they know how to mix the sorrel, they this responsive caregiving, they stimulating the child. There is a lot of reason to also believe that some of this shift is possible. ultimately food is what you need to be prescribing. And I agree with you that the shift can't be alone from shifting these behaviors or shifting the feeding behaviors only if there is no nutrition specific intervention. But all the other nutrition stunting protective behaviors are increasing, which are the lead indicators, which helps us to believe that the trend is probably true. Maybe the magnitude of decreasing comes with that big caveat around the data quality and missingness.
Thank you, Dr. Edzani. Thank you so much for that. And there was a question here as well. What is the role of the Department of Agriculture in the prevention of SAM in children under 5? Are there any programs in South Africa available? And anybody's welcome to answer that if they know, besides Dr. Edzani. Dr. Edzani, you know.
So the Department of Agriculture is the one that's responsible for the nutrition policy. So this National Food and Nutrition Security Plan that's been adopted, that is being drafted, and in there's an indicator of reducing malnutrition in children. There's stunting there. There's MEM and SAM, and it was previously not fully implemented. There was weak coordination.
Okay.
I think if the Nutrition Council is established, which is what was supposed to happen and never happened in the previous tenure of the plan, we should start seeing a lot more fire, because civil society will be more engaged and there will be very clear deliverables. I think what needs to happen, we need to see as the same response that we saw with HIV, and we're hoping that this Nutrition Council will bring that same fire with a lot of coalitions and organizations, which GrowGreat is part of. The Union Against Hunger, we're part of the maternal support grant coalitions, which are really pushing for implementation of this nutrition protective and sensitive interventions.
And then, Dr. Edzani, aren't they also supposed to be responsible for supporting communities with seeds, food gardening, things they might need?
Yes, they're supposed to do that. So
part of their
yes, absolutely. They're supposed to be doing that as part of the plan.
Yeah.
And the problem comes with implementation and when you take it down back to local municipalities. So there's also a problem of demand and just lack of information and awareness from the population around what needs to happen. But there's also a big problem of land. People just don't have the land to grow the food, which is land and water are the biggest problems when it comes to growing food.
No, thank you for that. And then another question from Gabriel. He wants to know, do you target a certain grams per kg per day for the children that you identify with malnutrition, and do you follow up?
So we fully work through the health system, the public health system with the community healthcare workers, and the program depends on the public response. So it depends. The one thing that we've seen a big positive influence is around moms applying for their child support grant much earlier than they would have. So we see much higher levels of coverage at the age of 1 in our population. But we do not track every single gram per day, but we track over time the child's development. We have struggled because we didn't have a digitized tool to be able to track the data live, which we now have in the Community Healthcare Worker app, which is still under development and not finalized. So there is still a lot of work for us to do because our data is still paper-based. And this is why we needed to do the retrospective chart review to sort of understand what's happening with our children. We have created a malnutrition register that helps us to follow closely the children on a month-by-month basis who are identified as children at risk and ensure that there is an intervention and they are linked to an intervention. But the referral pathways have been problematic, as it happens with the health system in general, especially the back referral after the community health workers have referred the children. And as you mentioned, sometimes they're referring to their own clinic where there's somebody at their own clinic who doesn't know how to plot out and confirm whether or not the child is truly stunted or if the child has MEM, because they only know how to use a MWAC tape, for example, or there are no tools in the clinic.
Yeah. And then Samantha and Cybridge, they want to know if it's possible to have this program rolled out in other provinces, if it's feasible, and how do they go about?
They can reach out. They can reach out to us. They can also help us to raise funds and also help us to advocate for the adoption of the program by government so that it becomes fully a government program. But yes, they can reach out to me at Edzani. Don't even know my email address. .growgrade.co.za.
And you can just put it on the
I'll put it on the chat. Yes.
And then Elmarie, I think is also referring back to Harun that there is evidence for community health worker visits improving outcomes. Yeah, so I think we've covered most of them. Then the last one I think would be how can DOH get collaborations with DOE so contraceptives can be given at school to reduce the scourge of teenage pregnancy? I think, yeah. Also, can there be a provision for teenage mothers to be allowed to be the ones coming with their babies rather than the grand? I think it's in relation to the question on the increase in young women or young girls wanting to rather formula feed than to breastfeed.
Oh, okay, yes. So I think we provide support to all moms, and in our Flourish program, which is a program that we deliver on our own, we have some Flourish classes which are mainly teenagers, but we have many classes where there are teenagers in the class. And what we found is that most of the teenagers who attend Flourish are unlikely to get repeat pregnancies after that. But there's also quite strong evidence around teenagers who attend support programs not falling pregnant within a short space of time after they have their children, especially those who go back to school. But contraceptives is a big one, and it's really the intervention that is needed at the school level.
Okay. Thank you so much. And then Dr. Edzani, in the last 5 minutes that we have, just to close off, I have a question from Lori, and I think it's related to the fact that you spoke about how stunting also leads to obesity in children. So she's asking, do you guys have a strategy to deal with obesity? Since you've identified that stunting can cause obesity, do you have a way of going about it? Or do you just deal with the stunting?
So we offer a holistic. So the community health workers will be trained on really providing comprehensive nutrition support and advice to the mothers around what food to feed the child, and in the house they're able to have bespoke solutions around. In Limpopo, mopani worms are a good source of protein, for example, or this vegetable is the one that you should have. And I think there's a lot of misinformation around store-bought foods and pureed foods, bottled foods from shops. And I think what we found really is the mums who have been counseled by the community health care workers who've been trained and also by our Flourish hosts are very clear around what is nutritious food. And we also, at a basic level, teach them how to be able to figure out food labels, but we're also strongly advocating together with other civil society organizations like KILA for front of package labeling, which allows mothers to be able to understand that be careful, this food contains too much salt, this food contains too much sugar. And we've been in a big advocacy campaign against Nestle, who are adding sugar in South African cereals, and they do not add sugar in any other cereals in other continents. They've just stopped in India, and in Africa, they are still adding sugar in infant cereals. And that is unacceptable. And those are the kind of things that drive these high levels of obesity amongst young children who are from infancy primed to be sugar addicts. But we work strongly with our community health care workers and our Flourish hosts to really understand the science behind the food and understanding which are the right food choices, and the importance of breastfeeding actually in being a huge protective factor for their children against obesity.
Just to add to that also, Dr. Edzani, I know that mothers sometimes think that processed foods are the best for their children. So even if they don't have money, they would go out and buy it just because they think that it's the best food for the child. Once they're educated on how it's not, that food that is made at home is also very good for kids, they tend to actually feed food from home. So it's a matter of education.
Absolutely.
Yes. And then just lastly, I think this one will be the summary. You're summarizing your whole talk, which will be a question from Marie, who's asking, what policies or what gaps in policies do you think are there that can actually help if they were to be closed or addressed? And then will be the last one, the last minute, and then we'll close off. And then I think Nozipo can come in and close off. Thank you so much, Dr. Edzani.
Thank you so much, Notando. And I think it's true. Once moms know what is best, moms always want to do what is best for their children, and they will always do what is best. And once they have the knowledge, they do the right things that they need to do for their children. And in terms of policy gaps, the policy gap is really focusing on the first 1,000 days. All the other policies, all the policies that exist, even around child nutrition, focus on the child once they are in a center. So what we need as a country is to find a solution for children who are obviously not in an early childhood center because they are too poor to afford it, or they are too young and their mothers don't have money and are poor and are vulnerable. So there is an important need to actually figure out what that nutrition-specific solution for those children 0 to 2 will be, and the children who can't afford to be in an early learning center where they're going to get food. I think in addition to increasing the child support grant to the food poverty line, there has to be a nutrition-specific voucher that mothers of children 0 to 2 months actually get, because I think all the pediatricians here know that the children who are dying in their hospitals are not 5-year-olds or 4-year-olds. It's the 0 to 2-year-olds who are being weaned in an environment of poor nutrition diversity, which is driven by poverty. So I think that is the critical gap that needs to be filled. There is the maternal support grant policy, which has been taken to cabinet, but has not been taken out for public comment. We need that policy to be passed because we know that the maternal conditions, maternal malnutrition drives child's malnutrition, and especially low birth weight, which is then a strong predictor for death, a strong predictor for stunting, a strong predictor for any illness that we can imagine. So we need to ensure that pregnant women are protected because they hold the future of their child's health in what they eat. And if they don't have anything good to eat because they're not protected, and especially the ones who are working in the informal economy, who obviously don't have UIF, won't have paid maternity leave, and they can't afford to take their child for care when they to go back to work. We really need to give a maternal support grant to pregnant women who are vulnerable in South Africa, and that will only cost the country 2 billion rands extra.
Thank you
which is
so
less
much,
than
Dr. Edzani.
not 1% of the
Thank you so
current
much. Thank you so
spend.
much. Thank you so much. And we're out of time. Thank you so much for your thank you. The next session.